All right. So today we'll be talking about news calls. So as a junior doctor, a lot of the times that you get called to see a patient is when a patient's news score goes up. We've discussed the news score previously in one of the previous lectures, but we'll also go over it very quickly here as well. Um, the news score is basically just a mechanism for nurses to see the vitals, well, not nurses, but all healthcare workers to see the vitals of the patient and then just give them a score so that we can quickly communicate and let people know how sick the patient is basically. So as a junior doctor, there's a lot of times where you'll get called and say, "Hi, doctor. This is Tarrington Ward. We have a patient who is using a 5. Could you come and have a look?" So that gives you an idea that, oh, okay, this patient is a little bit more unwell than someone who's like news 1 or 2, for example. We'll go over through all of that, so don't worry. This is a little bit of an interactive session, but there's no pressure. We're not going to put it on any one specific person. It's just using the chat function. If you guys are comfortable, just feel free to put in your answers or what you want to do next. Equally, you can open your mic and just and let me know what you're thinking. So let's get started. I think, the reason why I made this whole lecture series is because I myself, my first weekend on call, I felt quite scared, very unprepared. Even though we've studied for so long and we know so many things, you always feel like there's more and there's a gap in your knowledge. And then, you're scared of what to do next. Okay, I've seen the patient, they're okay, but how do I document that, all of that stuff? So I just thought that this lecture series would be like a safe space for everyone to just discuss all the things that might be worrying them. And then we can tackle some of the issues that might come up, very common issues that might come up as a junior doctor while you're working in the hospital. So like we've discussed before, this is the news system. So based on the patient's respiratory rate, sorry, let me just turn on the laser pointer there. Based on the patient's respiratory rate, their saturations, their blood pressure, their pulse, how conscious they are, and their temperature, you get a score. At this time, if you could just go on Google and just Google news score, so that's NEWS or NEWS calculator, news calculator, you get a link from MedCalc, which is again a great app. I highly recommend that everyone has it on their phone. But basically, it's just a digital version of this. Now, most hospitals are moving away from a paper system. So in my hospital at the moment, they're still using paper versions of this. So I have to flip through like 1,000 pages to find this page and then see how their vitals have been. Have they had any fevers overnight? Is their respiratory rate up? All that kind of stuff. I have to look through a paper. It is now thankfully becoming digital. This is a screenshot from another trust where it is digital. Our trust is going there soon. So hopefully in the future, you won't even have to do any of this. But I think it is important for you to see where the score comes from, because then you can see, why am I being called in? Because sometimes you will get called in due to an anomaly. So for example, sometimes you might get called to see a patient who's using like a 4 and you're like, how are they using a 4? I saw them this morning, they're fine. Someone took a temperature reading and it was too low, so suddenly they just got 3 points added onto their score, but otherwise they're fine. So you just go, you see them, they're fine, and then you just document that, oh, patient reviewed due to new score of 3, and they're fine. So if you have the MedCalc page open, I think it'll be useful for the exercises that we're going to do next. So we're just going to run through a few cases. What I hope that you guys will gain from this is see what kind of common things come up as a junior doctor when you're on the wards, and then B, see the approach to how you would approach someone like that. I mean, because it is very disorientating the first time that you have to do it. You're just like, there's like 1,000 possible things that could be going wrong. What am I, if I miss something? So we'll go through it in a systematic way. And then C, I think we'll be discussing the management, or at least the initial management for some of these cases. And hopefully that will make you more confident, because when I saw these things for the first time, I'll be honest, I freaked out a lot. So hopefully that will be avoided when you guys eventually go to see this. So let's begin. And again, feel free to, jump in whenever you feel like, but I'm just going to run through the case. Oh, yes, please go ahead, Tyron. Yeah.
Yes. So when searching for news, there were like there's news and there's news too. Will we be using the news or the news too?
They're both fine. I think they're quite similar, to be honest. I think my lecture might be based on the news score. I don't think there's that much variation. I think just one of the lines are a bit skewed. But anyway, you'll be in the same department. So it should
Okay.
be okay. Yeah. I can't see that much of it. Oh, okay. Yeah, just use the news score. I think the news 2 score might be a bit much. Let's just keep it simple. Just use the news score. Thank you for bringing that up.
No
So
worries. Thank you.
we'll start with the first case. So, it's you're working at the hospital. It is now 8 p.m. at night and you're on call and you get called about a patient. So it's a 43-year-old female. She's complaining of abdominal pain. She has been in ITU for the past 3 days because she had a road traffic accident. And she's currently admitted because she got pneumonia while she was there. So hospital acquired pneumonia. And normally she's fit and well. She's 43, she's fine. It's just unfortunate she got into a traffic accident and then she got admitted to the hospital. At any point, if you feel like I'm not going over any of the acronyms, just please stop me, but hopefully I'll go through them. So you get called about this patient, you're wondering, okay, what's going on? So the nurse tells you that, oh, there's abdominal pain for the past 2 days. And she's unable to sleep. She's been very tired, doctor. Every night she's very agitated. She's asking for, sleep medication and she's very bothered. But she's passing urine well. What, can you come and see her? So, what would you like to do or know next? Does anyone have any ideas of what they would like to do? You can feel free to jump in or write it in the chat, whatever you feel comfortable doing. I will give you a hint. It is part of the name of the lecture. If I think that is something to consider. All right, that's fine. We'll just go through the first case and then you'll see how this goes. So over the
Can we
phone,
ask for a news code?
exactly. So over the phone, you can ask for a new score. The way that my slide's set up is that I'm not going to tell you the new score because I want you guys to calculate it yourself. But usually, yeah, you just get a new score. And so these are the OBS. So the vitals basically. So she's saturating 95% on room air, 13 respiratory rate. Her blood pressure is 132 over 86. Her heart rate is 82, and her temperature is 37.2. Has anyone quickly tapped on the app and figured out what the new score is? Give it like a minute.
One.
Yeah. So the new score is 1, and I think it's a very useful thing to figure out, to go through that exercise and find out what the new score is. So she's stable. So if I over the phone was told, oh, she's news 1, I'll be like, I would ask what's she using 1 for. So then they would tell me. Do you want to tell me, Taimur, why she's using a 1?
It's the saturations.
Exactly. So the saturation, if it drops below 96%, you get 1 point. So that's the only reason. So honestly, she's stable. So over the phone, I have figured out that she's stable. This is useful for me because if I have 10,000 things going on, I know that this patient is not going to crash at the moment and they're stable. I can leave it for even an hour or 2 hours and I can go and see the patient. But anyway, it's useful just to get that in mind. What else do you think you'd want to know for the patient? So over the phone, this is all over the phone. Um, what else would you like the nurse to do? This is, in fairness, is a very tricky question if you haven't gone through this before. So what I usually like to do over the phone, again, this might not apply to your hospital, is I just ask for the notes. So I always ask, please, can you get the notes ready so that when I come and see the patient, it's very easy for me to flick through and find out what's going on. Because they're complaining of abdominal pain, I want to do a urine dipstick. So I want to make sure that they don't have a UTI because it has been 2 days. So if they haven't already done a urine dipstick, they can do a urine dipstick. Another thing that causes abdominal pain sometimes is constipation. So I'd want to see their stool chart. Usually, again, this is with their notes, but in specific, I want to make sure that it is there because if it's not, they can tell me and I can figure out, okay, that's one thing that needs to be done. And then the last thing that I'd want to do is an input-output chart. And again, it's okay if you don't say any of these things, but it's just if you remember that these are the things that you want to look at and you ask to prepare these things in advance, it's very useful because when you get there, you have a plan. It doesn't matter what the patient's currently doing or what they're feeling. I'm going to look at the notes. I'm going to see if they have a UTI. I'm going to look at if they're constipated or having diarrhea, and I'm going to see if they have fluids or not. Because all of those things are very easy to fix. If they have a UTI, you can give them antibiotics. If they're constipated, you can give them a laxative. And if they're having diarrhea, then you might need to consider sending that off for culture and stuff like that. And if they're dehydrated, you can give them fluids. It's very rare that patients are overhydrated, but anyway, that's something to consider. Yes, I saw a hand go up.
Hi, I was just sorry. I was wondering if we are able to have access to this PowerPoint presentation later.
Yeah, of course. I'll share it with you guys. No worries.
Thanks.
So these are all the things to consider when you do it. So okay, fine. You hang up the phone. You say, all right, I'm on my way. I'm coming to see the patient. You're free this one evening, luckily. So you come and see the patient. So what's the first thing that you want to do? Does anyone have any idea? You've arrived at the ward. What are you gonna do next? I know it's a very like basic question, but you'd be surprised because people freak out sometimes.
Talk to
So
our patient.
yeah, so go and see the patient. And you'd be surprised how many people show up and they're like, "Where's the scan? Where's the imaging? Where's the blood tests? Where's the notes? Where are the files?" And I think this is the safe thing to do because again, this came up in my interview for my FY2 post, is that you have to be systematic. So no matter what anybody has told you, go and just eyeball the patient and you will get good at this. I mean, at this point, I've seen so many patients that I can tell when a patient is not well and they're not doing well and I need to do something now, as opposed to, oh, they're sitting and they're having their soup, so I'm going to be like, "Hi, Mrs. Johnson, I'm just going to look at your notes, I'll be right back." um, so that is a very important assessment because again, if someone tells you a story and you just assume, oh, they're fine, and they were crashing and you didn't go see them, that's kind of on you. So just always just go and just quickly just look around the corner and say hi, just say hello, I'm one of the doctors, I'm just going to look at your notes, I'll be back. After that, you'd want to do an A to E assessment. We've talked about it before, and again, I will run through one with you, but I'll just tell you the pertinent findings for this case, just for the sake of time. So airway is clear, she's breathing is fine, SAT's 95, but besides that, everything is normal. If you auscultate it, it would be clear on both sides. Her blood pressure is fine, her pulse is fine, her refill is fine. She has venous access or like lines, basically, if you want to give her fluids or medicine, that's available. Her GCS is 15 out of 15. No one's checked her blood sugar, but she's not diabetic. I'm not too worried about that at the moment. And then exposure is the only one that I would be like, okay, now I want to examine the patient. So let's say you examine the patient, you do an abdominal exam because it is, she's complaining of abdominal pain. So on abdominal examination, you find a palpable large bowel. I know that sounds a bit like strange, but I can confirm that I have felt that, and you will, when you feel it, you will know that it is a palpable large bowel. It feels like a bag of like sausages almost, and you can feel it in the abdomen. It is quite interesting in that respect. As part of an abdominal examination, you're no longer a medical student, so you will do a PR exam with a chaperone, of course, or you can offer one. Some patients are like, just it's fine. But always offer and ask for a chaperone. So do a PR exam, and you did one, and you found that there was fecal loading. And then when you took a little bit of history from the patient, so you come in, you make sure they're stable, you do an ADE assessment to make sure 100% that they're stable, then you take a history. So when you take a history, you find out that, oh, I've been passing just liquid stools for like the past few days. There's nothing solid coming out, and I'm really concerned about that. So you've done all that, you've seen the patient, you've examined the patient, you've taken a little bit of history. What's the next thing you want to do? Anyone?
Investigations like labs and imaging.
Yeah, so that's a really good way yeah. So the next thing is to do that. I would recommend that you read the notes. So most of the time, the patients that you see are not patients that you know, because you're usually under one team, and when you're on call, basically, or you're twilight, or you're in a role that basically you're seeing patients that are not yours, it's always helpful to go and see a patient. Like for example, I once had a patient who unfortunately had a CT scan on Friday, and it was proven small bowel obstruction, and nobody had noticed that because it was Friday. And over the weekend, they'd been feeding this lady, unfortunately. So on Sunday, she started vomiting. So, but I went and saw the note. Well, I mean, I know it's imaging, but it was in the notes. It was written right there, but nobody caught it. But yes, you're right. Imaging is another one. Lab investigation is another one. We said that we do a urine dipstick, so we did a urine dipstick, and no appreciable disease. So you'll see NAD a lot. It just means no appreciable disease. And then you go and see what drugs they're on. So they're on Clexane. they're on cocodamol, and they're on coamoxiclav. So, and this is all regular medication. So this is the whole picture of the patient at this moment. Okay. So you've done all of these things. My question to you guys is, and again, you don't have to be right, but what do you think is going on? Does anyone have any ideas? Large bowel obstruction due to meds. Yeah, that's kind of close actually to what it is. So I wouldn't say large bowel obstruction because large bowel, like if you said that large bowel obstruction, they would be, fecal and vomiting. You'd have to keep them NPO. You'd have to, put an NG tube. They might need a surgery. You might want to do a CT scan. You're right. There is definitely an obstruct. I would say there's kind of an obstruction, but I wouldn't say that it's large bowel obstruction per se. So yeah, constipation is what I was kind of going for. It's the less severe version, but you're absolutely right. Your thinking is on the dot. It is due to the medication. So if you noticed, she's on cocodamol regular, and it's been like 7 days, right, since she's been in the hospital, or 5 days since she's been in the hospital. So that is a lot, and that does cause patients to get constipated sometimes. So you're absolutely right. It is overflow diarrhea versus a C. diff infection. So she's been on antibiotics for a few days as well. And there is always the risk that that might be causing the problem. But usually C. diff infection presents with more symptoms sometimes. And it has a very distinct smell and all of those things. But it doesn't matter because that's your differential. So going forward, this is what you're going to investigate for and manage. So does anyone have any idea what they would like to do for this patient?
Change her pain medication.
Okay, yeah, so that's definitely one of them. Yeah, so changing their pain medication is one of them. Anything else that anyone else would want to do? Oh yeah, stop. Yeah, stop the cocodamol is a good one. Hold it. Yeah, so that's one of those things. Part of management, I feel, is sometimes investigation and management come together. So is there any investigation that you'd like to do considering your differentials?
Stool culture.
Yes, a stool culture. Exactly. I think that would be very helpful. And in specific, maybe a C. diff PCR, because you're thinking, oh, it could be C. diff, right? At the moment, yeah, you could do a PA film to rule out large bowel obstruction. I think that's not a bad idea. You can definitely do that. I didn't write that, but I do agree that's probably a good idea to do, to rule out anything. I think I'd be more inclined to do that if they were in severe pain, but you're absolutely right. And again, every trust is different. So I can get a chest x-ray quite easily. I know that my hospital, for whatever reason, getting a PA is like really annoying. So that's why I didn't write it down, but you're right. And again, you can justify that because of the symptoms. You've gone and seen the patient. So I think the other thing that I really want to highlight in this lecture is that you are now a doctor. And I know it may not feel that way, but you are a doctor now. So when you do all of these things, you go examine patients, you take histories, you look at their notes, when you can now make decisions. And if you have a reason to do a test, you should push for that. You should say, yes, I would like a PA film. I want to rule out a large bowel obstruction. No one can say no, even if that's not something that they were thinking of. I wasn't thinking of that, but that makes sense to me, as opposed to if you said, oh, let's do an echo, I'd be like, maybe that's not the best thing to do right now. Or you said, let's do a CT scan, I'd say maybe let's hold off on the CT scan, let's do a lesser scan first. But you're absolutely right. So you hit most of the points, I'd say. So stool culture, C. diff, you want to kind of relieve their symptoms now though, because you can see, and even on PR exam you can see that there's a lot of feces. Just clearing them out might be helpful. So phosphate enema is very, very helpful. It works like magic. I have seen it on the wards. You'd have like these old, poor, frail women who unfortunately have been constipated. You give them 2 phosphate enemas and they clear it, and they sleep for the rest of the night, and it's like magic. So I highly recommend just keeping that in mind. But that is the acute management of the constipation. You also want to make sure that they don't get constipated again. So you give them laxatives, which one of them is lactulose. You want to switch their pain medication to PRN. So even if they are in pain, Obviously, you don't want them not to you don't want to pull their pain medication completely, but maybe just give it PRN. Again, they were in a road traffic accident, so they will be in some pain. But also giving regular paracetamol and PRN cocodamol is very helpful, and it does make a difference to patients. IV fluids, I think just in general, any patient that you feel that they're getting unwell, they're constipated, IV fluids is like a get out of jail card. It fixes a lot of problems. Like I have seen a lot of patients who've been deteriorating, and I'm just like, I have no idea what to do. Let's give them 500 ml of fluids, and I'll come back in an hour. You come back in an hour, everything is sorted, or you never get called about that patient again. So just remember, like hydration is very important, and people don't think about it, but it can really be your get out of jail card. And then the last thing is just maybe repeat their bloods in the morning. So, I don't know if this is infection, maybe there's something else going on. It's useful to just do bloods, just repeat bloods because you're like, I don't know, the last blood test was 3 days ago. Let's just repeat bloods. And no one will be upset with that. If it is something acute and you feel like a blood test would make a huge difference now, do the bloods yourself. But I think in this case, the patient's stable, it's news one, you've kind of identified what's going on. It's fine if you leave it for the phlebotomists in the morning. Okay, so that was one case. I hope that was helpful. Let's run through another two cases, I think, and then hopefully that'll be beneficial. Does anyone have any questions regarding the first case? Alrighty, so let's move on. So the next case it's again, oh, sorry, yeah, Taimur, go ahead.
So it's a basic question, but like about the enema, do we give it or do the nurses give it?
So I have done one because I just wanted to get things moving, and on a busy night shift, if things are busy, you can be very helpful and just say, oh yeah, just where is it? I'll do it. I've put suppositories in, I've done all that kind of stuff, but you don't have to. You can leave it as an order on the system, and it is the nurse's responsibility to give it. But I mean, it's case, but you develop a sense for these things of how urgent people are treating things. So, like some nurses are amazing, like they're incredible. They will come to you and suggest management, and you're like, yep, that sounds good. Let's do it. That sounds great. And then there's other nurses where you're like, this patient is septic. Can we please give antibiotics now? And they're like, oh, it's scheduled to be given in like 3 hours. I'm like, can we start it now, please? I've put it on this. Let's just start it now because the patient's unwell. Let's start it. So you get a sense for those type of things. So, with the lady that I'm remembering, she was yelling and keeping everybody awake at like 3 a.m. in the morning. I'm just like, can I just go and put the, enema myself? And I went with a chaperone with one of my colleagues, and I got everything cleared out. And so you don't have to, but it can be helpful sometimes. Abdullah, yes. Very slightly. Your voice is a little bit muffled.
Can you hear me now?
Yeah, I can hear you. Just go ahead.
Oh, sorry.
Yeah, that's better.
Is it better now?
Yes, it's significantly better. Yes.
Oh, okay. So I just wanted to piggyback on the whole like who does what. I think it's worthy to mention that some wards they don't have a designated phlebotomist.
Yep.
So when I was doing my elective in Newcastle at the neurology ward, the ones that do the bloods were the SHOs and the FY1 doctors that take the bloods.
Yep, 100%.
Yeah.
Yes.
Yeah.
No, you're absolutely right.
Just thought I'd mention that.
Yeah, like on weekends, for some reason I don't know how the have managed to get everyone to agree to this, but on weekends they only take 6 bloods per, and we have like 3 to 4. How they managed to agree to this rule? They're like, I'm only take, but that does happen. So yes, you do need to be aware of what services are available to you, especially at odd times of the day. Like another example is in our hospital after 8 p.m. If you want to get a scan, you can't actually call a radiologist because there's no radiologist on site. So we have a contract with a company called Everlight, and they are radiologists that are employed in other countries, like in Australia, for example, that are all GMC licensed and everything, but it's morning where they are, so they're in working hours. So we call them and we just tell them our story, like, hi, we'd like a scan. blah, blah, blah. And they vet it for us. And then the radiographers, which we actually have radiographers 24/7, they will get the request and they'll do it. So you just need to be aware of what your hospital services are at any time, at odd times of the day. But you pick that up as you go. But yes, Abdul, you're absolutely right. You need to be aware that sometimes it is going to be you. So just rather than deferring it, just go take the bloods, and don't worry about that. We have the last lecture, we'll talk about all these procedures and stuff, and hopefully that'll be beneficial as well. So we'll just move on to the next case. So it's 1 hour later, it's 9 p.m. It's a very exciting night. And it's a 52-year-old male who comes in. They just had an elective admission for a laparoscopic cholecystectomy with on-table cholangiogram. And they're using 6. So you just got called saying, oh my God, doctor, this patient is using 6. Can you please come? It's like an emergency type of thing. And you ask for a little bit more history and they tell you, oh, they had their operation yesterday and they've had gallstone pancreatitis in the past. That's why they had an on-table cholangiogram with their cholecystectomy. So you take a little bit more history and you find out that, oh, they came back yesterday from the theater. Everything was fine. There was no issues. But now, for some reason, the nurse was really good and she noticed that there's only very low urinary output. So they're only getting 10 ml per hour urinary output. And now they're very tired, but they seem well. So yeah, what would you like to know or do? Does anybody have any ideas?
What are they using 6 for, maybe?
Yes, perfect. Yes, exactly. So the title of the lecture. So here's the vitals. You can work it out yourself. Well, the answer is that they're using 6, but you can see here that their SATs are a little bit low and they're on oxygen. So if you look at the calculator, if a patient is on oxygen, they automatically get 2 extra points. The rest rate is a little bit, it's within normal limits, but it's going up. Blood pressure is still stable. 110 isn't terrible, but it's not, it's literally very borderline. Heart rate, obviously, they're tachycardic and their temperature is fine. So it's 2, 3, 4, 5. I think there's another 2 in there. Oh, this is 3, 4, 5, 6. So they're using a 6 because of these parameters. So in my hospital, a registrar would be informed anyway, but let's pretend that they're busy in theater and it's just you. Okay. So what else would you like to know or do?
So why are they desaturating? That's my first question.
Okay.
So in order to find out, other than a physical exam, maybe a chest x-ray.
Okay. Yeah, perfect. So that's a good idea for what to do later on. Absolutely. Over the phone, though, you can ask for 2 things. In fairness, this is very surgical, so I don't blame you guys for not thinking of this. Besides getting to know, sorry.
If there's, I mean, one of the complications, I mean, not complications, but side effects within like 24 hours of surgery, like post-op. I mean, I'm just going through the list, so like atelectasis or pseudo obstruction or
Yeah, there's like a million causes.
output is kind of.
So you're absolutely right, and you're highlighting something that I used to do a lot as well, which is that when you get a call, you kind of start thinking of differentials, which is great, but you still need to go see the patient, and you still need to do all the examinations because it might be something that you're not expecting. And if you just think that, oh, this is atelectasis, for sure, it could be, but this is 100% atelectasis, and I'm just gonna I'm gonna look out for that. You'll miss other things. So right now, yes, their saturation is low, but did you wonder if their saturation has been low since the time they came into hospital or since since their operation? Because the other problem they're complaining of, which I now know is probably worse, is they have low urine output. So that for me is more of a problem than their saturations being low on oxygen, especially like if they're still being managed on the ward. But you're absolutely right. This is why it's always important to have a list of things to rule out. So if you ask for a chest x-ray with those vitals and on oxygen, absolutely. No one would have any problems. You could call radiography right now and they'd do it. At least in my hospital. I'm hoping other places are the same. So exactly, you just need to keep your mind open. The other thing is, because she was saying that, oh, there's poor urine output, a lot of times what happens is that that catheters block. So sometimes all you have to do is just literally just flush the catheter. So you just take a syringe with like, I don't know, 20 ml of normal saline, and you just flush it. And suddenly, all of a sudden, it clears the tube, and suddenly loads of urine comes out, and that's it. That's all that was actually going on, is that the catheter was blocked. So nurses usually are very good and they flush it themselves, but sometimes they just freak out in the moment, especially if it's like a urology patient who just had urology surgery and there's blood coming from the catheter, which is like all the time. And then suddenly it stops working. The nurses freak out. They're like, doctor, it's not working. You just have to tell them calmly, can you flush it? And then they flush it, and then suddenly it starts working, and they're like, oh yes, it was just clotted. So again, I'm going on a tangent, but these are things just to consider. So anyway, moving forward, you come and see the patient again. So we're going to do the same exercise. You're going to come and eyeball.
Sorry.
Yeah, sorry.
How did you just flush it with normal saline? Do you just where the port is?
Yes.
Or,
yeah. So
okay.
you literally, well, so if it's a 3-way, it's really easy. But if it's a 2-way, yes, you just disconnect it from the bag, and you just there's a specific syringe which has the end which fits onto it. But otherwise you can take the other one and squeeze it in, but don't do that. And then you just flush it, and you'll see that you'll feel like the resistance like give way. Like in the beginning it'll be very difficult, and then suddenly it'll just like open, and then you'll urine will start coming out. So just be ready for that. I'll mention this in the next lecture, but whenever I do any procedure, I always have a pot with me. So whether it's putting an NG tube or putting in a catheter or anything, just I like having a pot with me, because in the event that anything goes sideways, I have something to capture whatever's coming out. But yeah, that's how you do that. So you come and see the patient, you eyeball them, you make sure that they're stable. Again, if they're crashy, they are new 6, so you don't want to be like, oh, I'm going to read your notes, and they're literally going like so it's important to go and assess them. You do an ADE assessment again, and this time will be nice, everything's fine. Okay. In E, you notice that they have drains in their stomach, and the drains are working. There's 15 ml of serous sanguineous fluid, but that's fine, especially day 1 post-op. That's completely fine. You look at the dressings. So anytime you're on surgery, and any patient who's had a surgery recently and they're becoming unwell, please look at the wounds. You will be surprised. Those cases where they say, oh, patient was bleeding out from the stomach, that stuff happens. So please, please, please always look at the dressing. You don't have to remove it, but just go and see it, because if they're bleeding out from there and you missed it, that's going to be a problem. Especially this patient, because he's tacky and his blood pressure is a little bit low, especially if his blood pressure was sat like at 160 and suddenly it's like 110, you have to rule out bleeding. So this is why you always, it's an interesting job in the sense that, oh my God, there's like 10,000 things. They could have a chest infection, they could have a urinary problem, they could be bleeding out from their surgery site. But again, if you take a systematic approach, you'll be just fine. And then you look at the catheter bag, obviously, because that's one of the reasons why they called you, and it shows that there's low urine. What's the next thing you'd like to do? All right, it's the same as before. So you'll just look at their notes, input, output, see how much fluids they've gotten. And you'll see, with this patient specifically, they have not been giving fluids to this patient. So that would be a reason for, what's it called? Low urine output. As they say, it's pre-renal, renal, post-renal. You've cleared the post-renal cause, you put fluid in and you flush the catheter, it's fine. The renal, it doesn't seem like that would be an issue. You could check their renal function and make sure that they don't have CKD, but they don't, because he's pretty young and healthy. And then pre-renal, so they just did not have enough fluids by the looks of things. You look at their notes, everything's fine, there's no big deal. And you just look at their drug chart, they're only on Clexane and cocodamol PRN. So what do people think this is? So it's probably dehydration. They haven't been given fluids, they have low urine output, they're post-op. It happens a lot. But again, you have to make sure that it's not anything sinister. It's not sepsis. But again, there are other signs. They would be feverish, they would be acutely unwell. You can tell. After seeing loads of septic patients, I promise you can kind of tell when a patient is septic. When they're, you also have to rule out bleeding and anastomotic leak post-operative. Those are very big complications as well. The management for this patient obviously is fluids. So again, a bag of 500 ml normal saline, assuming, so this is just how I do it. I just ask, patient has heart failure? No, just give him a 500 ml normal saline. I'll come back in an hour. It does wonders. And again, when I don't know what to do, that's literally what I do first. And then in an hour when I come back, and if they're not any better, now I can call my doctor, my registrar, and be like, doctor, I've given fluids. They're not responding. Could you come and have a look? I'm really concerned. They'll be, oh wow, yes, very good management. You know, you did something. But it seems basic, but it's really nice. You want to make sure that the urine output in 1 hour has kind of gone up. More realistically though, because on a busy night, like I remember I had one of these patients, you'll come back like in 3 hours and 4 hours and you'll see how much urine they've produced. And we had one patient, we had to get ICU involved because it looked like they had like acute kidney failure. But thankfully, after like 5 hours of resuscitation, they started producing urine. We're like, yes, don't have to send you to ICU. But that's just something to consider, is you just keep checking. You have to keep an eye on these things. You can't just be like, oh, I've given the fluids, that's it, we're done. You have to keep checking. You want to repeat the bloods to make sure the renal function isn't bad. Like if this was, if they're deteriorating, you want to get specialists and more help involved. And then you want to prescribe the maintenance fluids for the next 24 hours. So the calculation is 25 ml per kg per day, 25 to 30 ml per kg per day. And if you do the math on that, I think if it's a 70 kg male, 70 times 30, it would be 2.1 liters per day. So if you prescribe 2.5 to 3 liters, depending on the weight, assuming they're more than 70 kgs, it should be fine. But that's usually what we do. So that was a very realistic case. But again, if you're worried about their chest, get a chest x-ray. Have a listen to the chest x-ray. I can now also tell you that after examining loads of chests, I can find crackles and crepitations, and you can actually, all the stuff that they say in books is real. And based on that, you can say, oh yeah, I heard crackles. Yep, we'll get a chest x-ray. And then if, all of these things, you have to keep an open mind because it can be anything. If they're bleeding, they're septic, you have to keep that in mind. And that's a very good indication for a CT scan. I've also done that sometimes where you need to get a CT scan and that's the indication. So I'm just going to zip through the next two, hopefully, and then I might go a little bit over, but hopefully we'll keep within time. So the next case is the next hour, obviously at 10 p.m. because, this is a very busy night, but it unfortunately does get like this sometimes. So just to be nice, it's now going to be a general medicine ward. So, I'm going to stop talking about surgery. And this is a 65-year-old man who's admitted for cellulitis, but he has a background of hypertension, and he's on the general medical ward, and he's using a 4. So I'll give you the vitals now. So these are the most recent vitals because I asked the nurse over the phone, well, why is he using 4? So their heart rate is up and their blood pressure is down. And 1 second. Oh, sorry. Lost the plot there for a second. So so they look better than they were on admission, but they're complaining of palpitations. So very medical thing, don't call the surgeons for palpitation patient. So what would you like to know? Again, same as before, just prepare the notes. I will say with anything cardiac though, very useful hint, and it makes you seem like I got this. Just ask for ECG. Just anytime I'm complaining of chest pain, oh yeah, could you do an ECG? I'll be on my way. Palpitation, anything, just ask for an ECG always. It makes you look good, and it usually will find the problem as well, and then you can deal with it after. So let's do an A to E assessment. You come and see the patient, you want to do an A to E assessment, and we'll do each step together. So airway, clear and patent. B, the chest is clear in auscultation. They're not having any shortness of breath. The respiratory rate's fine, 16, and they're sounding 98% on room air. That's great. Circulation, you check their pulse and you can feel that it's irregularly irregular. There's no JVP seen, but their heart rate is fast and their blood pressure is low. Their GCS is fine, so you just ask them, hey, how are you doing? Fine. You can assess that very quickly. Someone did a blood sugar, so it's called a BM. I believe it's because of the company that used to make the meters were BM, so they just call it BM still here. And then the temperature for the patient is normal. And then E, you can just see that the cellulitis is basically the same that it was. It was marked, and the calves are soft, non-tender. So it's always helpful to just feel their calves, because patients get PEs a lot, unfortunately. And if you just can say, "Oh, I checked their calves; they don't have a DVT," that is sometimes reassuring. There is the well score. You do need to use it whenever you request for a CTPA. The radiographer always asks what's the well score. But anyway, this is how I would write a note. So if I came and saw a patient, so if, for this case, asked to see a patient, so ATSP regarding regarding palpitations, and then I would say A, airway clear, B, chest clear, C, irregular pulse, D, I would write this exactly the same on my note. So anybody who comes can see that I've done an A to E assessment. You'll see that registrars don't do this anymore, because obviously they have enough experience. They can just say, yeah, A to E clear, whatever. But as a junior doctor, I think it is very important for your sake that you do this, because A, you won't miss anything. If you do it step by step, you won't miss anything. And then B, it just looks good, on your notes. So you've done the ADE assessment. You go and you see the notes of the patient. So the patient has a background history of hypertension. You can see that in the initial clerking that, they wrote that he came in with hypertension. But there's no mention of atrial fibrillation in his notes. So it doesn't seem that he has atrial fibrillation, even though now you're feeling an irregular pulse. That's probably what you're thinking in your head. You want to think of any infections, anything like that, or just see their recent bloods. So you go in the system and you see that, bloods were sent in the afternoon, and they also sent a blood culture earlier. They're probably having a fever at some point, but they haven't come back yet. And then you just see their drug charts. What are they on? So they're on antibiotics and they're on Ramipril, probably for their blood pressure. So we're gonna do my favorite exercise, which really caused me a lot of pain one night, is we're gonna look at ECGs. So this is the ECG on admission. I don't know if you can zoom in. I did manage it last time.
We can.
Oh, you can? Okay.
Well, I can on my phone. On my phone, I can. I don't know about the laptop.
I'm pretty sure you can as well. There's a button somewhere, and you guys are hopefully more tech savvy than I am. So you can see the ECG here. It seems pretty regular to me. I always just do so the rate. So it's whatever is in one strip. So one strip is usually 10 seconds, and you want 60 seconds. So it's always 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 times 6 is, does anyone, 66, I think. So that would be the rate. Though I think this actually isn't one strip. This is two strips. But anyway, it's a normal ECG. I'm terrible at ECGs, but I can at least detect that the rate is regular. There's no MI anywhere. I'm just looking to see if there's any MI. I don't see any. And that's about it. But the nice thing of getting the initial ECG and the next ECG, or the one that they just did, is you can compare. Now, I am not a medic, to be honest. I'm a doctor, but I don't like to subscribe to the medicine doctrine. But I can clearly see that there is something wrong here that is not here. And the first thing is the rate. And I can already see that the rate here is a lot faster than the rate here. And on top of that, I can see a little bit of these like kind of squiggly lines. So that doesn't look right to me. That seems like atrial fibrillation. So I can now say, well, I'm going to call, my registrar regardless, but it seems that they've gotten some new onset AF. That's what I'm thinking. This stuff is weird. I would probably ask for some help as well and say, is this an MI? I don't think so. They're not having any chest pain. But I would definitely get someone to look over this. So even if you're bad at ECGs like me, always just compare normal versus what is happening now, and just stick to the basics. You can see the rate is off. You can see the waveform is off. At least you can tell someone over the phone that, this is what's happening. Can you, come and have a look? So I think that's the benefit of that exercise. So the diagnosis, I think, here is fast AF, possibly secondary to sepsis. So you always have to think about sepsis in terms of new onset atrial fibrillation. Patients who have atrial fibrillation from before, obviously, you wouldn't be too concerned. But if they have new onset atrial fibrillation, that is something to be worried about. Because what's the reason? Why does, your heart doesn't just start, dancing for no reason? In terms of management, this is just what I've found. has helped me when I've had to manage these patients, and also what I've seen when I've called the medical registrar and be like, what do you think we should do? Giving fluids, great idea. It helps. I actually had a patient who was in atrial fibrillation. We gave them some fluids and they settled. So I was like, great, you're just dehydrated. Fantastic. But if it doesn't work, you want to investigate, is there another cause for the atrial fibrillation? So making sure that their electrolyte levels are fine. So obviously you're worried about hyperkalemia, hyponatremia, all of those things. So in a hospital, if you send a patient's bloods off, they will usually store the blood sample for 2 days, depending on which hospital you're in. So let's say that initially you didn't check the electrolytes level for the patient for any point. You can send a form down and say, I would like for you to take a blood sample from the one that I sent like a few hours ago and just look for electrolytes. So that would be helpful in case it's not there in the system. Review in an hour. I think any patient who you think is unwell, it's useful to just make sure they're stable, do an intervention, and then come back in an hour and see if it improves. If it improves, it's fine. That's great. Their heart rate comes back to normal. Their blood pressure comes back up a little bit, and they're fine. That's fantastic. Maybe this is all that they had. They just had low, they just had, maybe they're just dehydrated. But if it doesn't improve, you should definitely get senior support. I don't recommend you starting, a beta blocker or trying rate control or cardioversion. That is definitely a senior thing to do. So just get them involved. The medical registrars are very nice, and if you've done all the steps on your part, they'll be more than happy to come and help you. And then obviously consider if you want to change antibiotics if you think it's sepsis, but usually it's not. Okay. I hope that was helpful. We will do one more case, and then hopefully if there's any questions, I can address them there. So this is the last case of the night. I think I made this maybe a little exciting, but hopefully there's a lot of learning points in this. So it's midnight. Always when things start going bad is after midnight or 1 a.m., 2 a.m. That's usually when things go sideways. You're on the respiratory ward this time. Very real possibility for a lot of you doctors now. And you've gotten called about a patient who's using 8. Now, this is a little exaggerated. There would definitely be senior support who's probably aware of the patient, but you will still get called and you'll have to go see the patient. Now, it's the same as before. You don't need to freak out and think, oh my God, they're dying. It just means that their parameters are a little bit more skewed than anyone else, but you can still do this. So this is a 58-year-old male admitted with an infective exacerbation of COPD. And their past medical history is COPD, obviously, ischemic heart disease, and gout. So a very medical patient, your classic respiratory ward patient. So they were admitted earlier today, and they were transferred from the medical assessment unit 2 hours ago. So the MAU, so in any hospital in the UK, there's an MAU and a SAU and a PAU. It all just means like these are where the patients get seen if they're referred from A&E, and then you decide, the surgical team decides what they want to do with them next, if they want to admit them or discharge them. It's just a logistical thing because, again, there's just not enough beds in A&E. There's so many patients. So that's where they are. So what happened is the patient came into A&E probably. They were seen by A&E. They said, okay, this is a rest patient. They moved them to the MAU. The medical team saw them on MAU, and they said, yes, we need to admit this patient, and they admitted the patient. So they've been having shortness of breath since they arrived, and now their saturations are getting worse. So obviously we'll get to what they're saturating for in a minute. They're currently on 24% oxygen via VM. Does anyone know what a VM is? So it's
Venturi mask?
It's a Venturi mask. Yeah, exactly. So you've seen them probably. Depending on the type of mask, it gives a different percentage of oxygen to the patient. But it's just telling you that this patient is not doing that great at the moment. What would you like to do next, or what would you like to know? As always, you just want to ask, okay, why are they using 8? Like, that's so high, But the reason being is their saturations are not looking that good, and they're on a lot of oxygen. They're breathing really fast. Their blood pressure is fine at the moment, like it's high, but it's not something acute. You're worried about low blood pressure and super high blood pressure. This is fine. Heart rate is okay-ish, and their temperature is borderline, but it's fine. But they're using an 8, so you have to just be like, okay, that's not good. I always, when I get told a crazy number, I always ask them, has this been the case all day? Or is this the case now? Because if it's been the case all day, it just means they're getting worse over time, which means that they should be stable. If this just happened now, that's a medical emergency because that means something acute has happened and they've suddenly gone from 1 to 8. That's not good. But anyway, you want to go see the patient. So you just ask the notes to get ready, and you might want to consider an ABG or a VBG because when a patient's so that's one indication to do an ABG. If any of you were wondering why do we do ABGs, is when a patient's having some trouble with their respiratory system, definitely doing an ABG would be helpful. And you also want to see how well they're compensating and whether they're acidotic or alkalotic, acid-based stuff. And you need to know that information if you want to refer this case to ICU, which probably is something that I would suggest. You need to consider if you want to do that. And you want to ask when was the last one done as well, because if they were just pricked 5 minutes ago, you probably don't need to prick them again. Which unfortunately I've made that error once, that I accidentally took bloods from a patient who had bloods taken. But the patient was so nice and they're like, oh, I thought this was different. And I'm like, why didn't you tell me the nurse just took your bloods? And he was fine. Yes, how can I? There's a hand up.
Yes. Hi, doctor. For the ABG, do we do it or do the nurses do it? And during the time that you've actually worked, how many times have you done it?
So I've done an ABG maybe like 7, 8 times. But I will discuss how to do an ABG. It's a lot easier and a lot less scary than you think. I actually prefer doing ABGs over taking regular bloods because there's a less chance of failure, to be honest. It sounds scary, and for some reason they've hyped it up as like, oh my God, it's so painful. You have to give them local anesthesia and all that. I have, like, first of all, if you're doing it most of the time, these patients are super sick and they don't feel anything. And second of all, it's really quick and the needle is tiny. Like the needle that I would use to give them local is the same needle that I'm going to take the sample from. So rather than me numbing it, I just very quickly just take the sample and leave, and they don't even notice half the time. We will definitely go over ABGs. I don't think nurses take ABGs anywhere. It has to be a doctor. I think in ICU, in fairness, I think the ICU nurses can take ABGs, but besides that, it is always a doctor. And it's usually the junior doctors because registrars don't have the time or the interest in doing them. But again, I will go through it. I am pretty good at ABGs. I will put my hand up and, whenever we need to do an ABG, I'll do that. I hate taking blood. I always miss. But we'll talk about that in the next lecture, hopefully next week. So yeah, so you see the patient. Obviously, you're going to do an A to E assessment always. You can see the patient and they're breathing fast because they have shortness of breath, but you knew that even from the vitals over the phone that they would be like that. So it doesn't scare you that much, but you still want to do an A to E assessment. So thankfully, they're still speaking full sentence, even though they're breathing quite heavily. They can say, hi, doctor, it's been happening all day, but they're still breathing full. So airway is patent. Good. Okay. You can hear them struggling to breathe. They're centrally cynosed, and you hear their chest. It's crackles and wheezes, but it is what it is at the moment. They're breathing a little bit fast, and their saturations are what they are, and they are on oxygen. They have the mask on. Their heart sounds and our pulse is regular. Their pulse is okay, and their blood pressure is fine at the moment. Their GCS is 15 out of 15, and their blood sugars are normal, which is great. And then on examination, their calves are non-tender, and their abdomen is clear as well, so it's not anything wrong with there. It seems like it's just a chest problem that's causing all of this. So the next thing that you probably want to do, I hope, is just read the notes, and just see what's going on. So you go and review the notes, and you can see that only the initial clerking notes. So clerking is just, the junior doctor has come, taken a history examination, they've written what medication they're on at home, and they've just written it down, and that's it. And then the MAU consultant came and saw the patient, and they said, yes, shift to rest board, and that's it. You don't know anything else that's happened since. You can see what blood tests have been done. So in the A&E, which was like maybe a few hours ago, they had elevated white blood cell count, so they might have an infection, but that's really about it. They did a chest x-ray when they came in, obviously because they were having all these symptoms. It just shows chronic COPD changes and bronchopneumonia, so they have an infection on top of their bronchiectasis, basically. But that's about it. And then they did an ABG when they came in, obviously just to see how they're going. Now ABGs, I'll be honest, I used to suck at ABGs, and even sometimes I still stumble. But after doing quite a few, you become more confident and you see what to look out for, because in medical school, I feel it's a very abstract concept, and they just teach you, oh, these are the values, this is normal, this is not normal, et cetera, et cetera. But when you start practicing, you'll see that there's a huge benefit. It can tell you what to do next, whether the patient needs oxygen, what fluid replacement to give, all that stuff. So for this patient, you can see that their pH is normal, so that's good. I always take it one step at a time. I think the craziest thing with the ABG is that people just see it and they like try to calculate all at once. Just do it simply. They're normal. Their pH is normal. Good. Okay. What else? Their PCO2 is a little bit elevated. That means they're trapping carbon dioxide. Okay, makes sense. They're COPD. Their oxygen is low, and their oxygen is low on 24% oxygen. You have to keep that in mind. Whenever you do an ABG, you need to know two parameters. You need to know their temperature and what oxygen they're on, because 8.3 might not be that bad if they're on room air. That just means they need some oxygen. But 8.3 when they're on 24% Venturi mask is really bad, because it's like you should be like super saturated with oxygen. Why aren't you getting any oxygen? Their bicarb has gone up. So their body's, trying to compensate for all the acidosis because they're trapping carbon dioxide. And their base excess is -4. Does anyone know what base excess is? That's completely fair. I didn't know either until I had to deal with it. But basically,
questions a lot on PassMed, but I have no idea what it means.
That's completely fair. So until I was seeing so many weird base excesses, I was asked about what it meant. I had no idea. But basically what base excess means is if their pH was abnormal, how much base or acid would they need to bring it back to normal? That's all it means. So here it's not too bad. Base excess -4 just means that they need a little bit of base to come back to normal, which they're already normal in fairness. But it to correct all the abnormalities, how much base or acid you need. Most people it's just like a severity score, like how badly are they acidotic, how badly are they alkalotic. Just think of it like that. I think I should have included an example where the values are off, so it'd make more sense. Like if this was -20 and their pH was like negative, or was like 7.2 or something, it would make more sense. I'm sorry I didn't do that, but that's basically what base excess is. So hopefully the next time a consultant asks you, you can be really smart and say it's how much base or acid we need to correct their their acid base disorder, and they'd be like, wow, you're amazing. But the drugs for the patient is they're on salbutamol nebs, obviously because they're short of breath and they're asthmatic. Same with ipratropium. They're on antibiotics because of the infection that they have. Ramipril probably because of their high blood pressure medication. And then allopurinol for the gout. So that is the whole picture. Does anyone have any idea what's going on with this patient, seeing what is going on in overall? I think this was actually very difficult. I don't know why I wrote this for you guys. So it's type 2 rest failure. So basically, if you go back to the ABG, you can see that their CO2 is up and their oxygen is low. So that is respiratory failure. If the CO2 is normal, I believe, I might be wrong here, if they just had a hypoxia without hypercapnia, it's type 1. And if they have hypoxia and hypercapnia, it's type 2. That's all you need to know. That's all I remember. But basically that's what they're having. Their lungs are not working. They're not respiring. Their respiratory system is failing. So what are you going to do? Well,
Can we increase the oxygen percentage?
yeah, you can increase their oxygen percent, and I think that's a really good idea. Again, it really it really depends on which center you're on and what resources they have. But if they have another Venturi mask, it's worth upgrading that. I think repeating
put them on non-invasive pressure ventilation would be useful here, or unless they can
it's
maintain
not a
the
bad
air.
idea. With that, usually you need a senior to come sign off on that. You can't just run around giving people like BiPAP and stuff. But that is a good idea. Absolutely something to consider as well. I think I think again with management, you have to consider that it is investigation as well. So that ABG was done when they were admitted like 3 hours ago. So I think it'd be worth doing another ABG just to make sure they're not getting worse, they're not getting more acidotic, they're not getting, they're everything's still normal. So you do a repeat ABG. They're not acidotic yet, which is good. Um, they're still retaining CO2, which is, I mean, it makes sense with the picture, but now their oxygen has gone down, even worse. So that's like a red flag. That's not good. And then on top of that, the bicarb's still where it is, and the base axis is the same. Because again, I just wanted to point out that you have to keep an eye on these two, because if their oxygen level starts dropping and you're giving them oxygen, it means something is going wrong. They're starting to fail. Giving salbutamol with nebulizers with air is sometimes helpful. And then increasing the oxygen to a 35% venturi mask is a good idea. But I'll be honest, in a case like this, you'd probably want to get senior help. Like you want to get this patient admitted to ITU. They might not be able to have non-invasive ventilation for too long. They might actually need to be intubated and mechanically ventilated because they're not doing that great. But again, that's not your decision. But you have at this point done everything you can. You've looked at them. You've tried increasing their oxygen. You've tried to make sure that they're on antibiotics. You're sure of what their acid-base status is, and then you can present this information to senior. I don't think you will ever be asked to manage something like this by yourself. If it is, it's a really bad night in the hospital, and that's okay. That happens. But just go through the steps, and it should be all right. I think that is it for now. Does anyone have any questions in general, in that last case, overall, anything like that? If I could ask, it takes literally 2 seconds, but it would mean the world if you could just fill out this feedback form, just scan it, and give it and just fill it in. If you're watching a recording of this, it is still up. You can still give feedback. It makes a huge difference. It really helps with my application, so I'd really appreciate it. Yes, Taimur, how can I help?
Yes, so my question was regarding the AFib case.
Mhm.
So I know, like, obviously, like, books are very different. So I want to know how we do it in, like, clinical life, because from what I've read in books is that if it's AFib is unstable, you immediately go for synchronized cardioversion. So in real life, do we immediately call someone to do that, or do we first, like you said, like, we actually give fluids and all of that, and we wait until if it gets better?
So it really depends on the severity and the stability of the patient. If I see any new onset AFib, I will call a senior, regardless. It just depends on how stable they are. What you're describing is pretty severe. I'm pretty sure they would be tachycardic hypotensive, and it's really affecting them. They're symptomatic AFib, because you can have asymptomatic AFib. I just included a case of kind of asymptomatic AFib. It's like palpitation. It makes sense. Their heart's not breathing in a regular way, but their vitals are still stable. Unstable AFib is managed in a completely different way. But you will not be expected to cardiovert anyone unless it's a code, which is different. But if it's just AFib, call the medical registrar on call. They need to come and assess the patient. They will decide, because with AFib, it's rate control versus rhythm control. What you're talking about is rhythm control, which is cardioversion. But sometimes patients can be controlled just on rate control. So just starting them on a beta blocker does the job. So why would you shock someone if you could just give them a pill and it works? You know what I mean? Go ahead.
Yeah, so thank you very much. My other question is regarding the News 8. So I remember from one of your last lectures that I guess, I'm not sure if I remember correctly, but above 7, you have to inform a consultant,
Yeah.
like,
Registrar.
so a registrar. Okay. So we just so in this case, would we even we just inform them that there is a News 7, and then we would go look at the patient?
So the only time that I've been asked to see a patient who's News 7, over the phone, when the nurse told me that it was News 7, I only asked 2 questions. Is this patient under us? Is the registrar aware? So the patient was under us and the registrar was aware. So I said, okay, I'll go and see the patient. They just need to be aware. They don't need to come and see the patient. You should always, and I mean, it's your patient. You should always go and see the patient first. I know it sounds scary, but you should go and see because if it's something as simple as, oh, they just need some fluids, because, because the one that we had, so I'll tell you the story. We finished rounds, everything was fine. And then I get a call from one of the outlying wards saying, oh, there's a patient under you who's post-op. They had their surgery today and they're using 7. And I said, are you sure this is our patient? Because we didn't see them during our rounds. And is the registrar aware? Because they need to be aware of this. So they said, yes, this was a patient that happened electively. The case was done today. We weren't aware. And the consultant did it without telling us, which is fine. That happens all the time. And the registrar is aware. They've asked you to go and see the patient. And I said, fine. So I like rushed over there and just saw what was going on. It was, again, just one of those cases that, temperature was a little bit low. So they got 2 points from there. Their heart rate was a little bit high. Their blood pressure was a little bit low. You know, they were fine. They were stable. They were talking to me. It was completely fine. But again, you know, you have to go and see them. And I wanted to make sure she wasn't bleeding out because she just had a surgery today. So I made sure her wounds were dry and everything was fine. And by the time the registrar had come, I'd already started fluids. And he came and he saw, and within 10 minutes, her blood pressure came a little bit up and her heart rate went back to normal. So that's it. It seems terrifying. I completely agree that, oh my God, you're first into, oh my God, it's new 7. Okay, I'm going to call the reg. Don't do that. Always go and see the patient, because what the registrar will do next is, where's the patient? Oh, they're in this ward. Oh, how are they doing? I don't know. I haven't seen the patient. Oh, what's their blood pressure? I don't know. What's their, like, think of it from their end. Like, they have just been told to do a task without any information. What's better is you go gather as much information as you can and then call them. And if you go and they're like crashing, like the patient's like, it looks like they're going to die, just call the crash team. No one will ever be upset at you for calling a code if you think that even if it's a peri arrest, no one's going to be upset at you, especially if the F1 does it. We would rather that you call the code team and be wrong than miss a code. So don't worry. And there's always support. That's the biggest thing I want to kind of highlight, is that it looks like there's a lot of things going on, but there is always support in the hospital. So hopefully that answers that question. Does anyone have any other questions?
Thank you very much.
No worries. Happy to help. So yeah, thank you, everyone. I really appreciate you guys giving your time on a weekend and coming. Hopefully this has been beneficial. I'll put the recording up somewhere and share the link. And then I will circulate the PDF of this very soon, and hopefully you guys can share among yourselves. And that is that. Please feel free to contact me if you need anything, and I will see you guys next week. So take care and have a great week.
Thank you very much, Dr. Shaheer.